Welcome to Quality Time, a Houston Methodist leading medicine podcast. I'm your host, Dr. Schaal, a clinician scientist and a retina specialist, and I serve as the Chief Physician Executive of Houston Methodist, located in the world-renowned Texas Medical Center. I passionately believe that quality is the heart of healthcare, and a commitment to quality is essential for every healthcare system. Join us each month as we discuss the latest advancement in quality in healthcare with clinicians, researchers, physicians, industry experts, and thought leaders who are as passionate as I am. Today, I'm excited to welcome to the podcast Dr. Tejal Gandhi. Dr. Gandhi is the Chief Safety and Transformation Officer at Press Ganey, and she is responsible for advancing the Zero Harm movement to improve patient and workforce safety. Dr. Gandhi is a recipient of the John Eisenberg Patient Safety and Quality Award, given in recognition of her contributions to understanding the epidemiology of medical errors in the outpatient setting and for developing prevention strategies. She has also been named as one of the 100 most influential people in healthcare by Modern Healthcare magazine. Welcome, Dr. Gandhi.
Thank you so much. So happy to be here.
We are delighted to have you, and please tell me a little bit about yourself.
Well, let's see. I am an internal medicine doctor and live in the Boston area and have been working in the quality and safety space for a long time. I actually started my career as a patient safety researcher, and as you mentioned, did a lot of work on patient safety in the outpatient setting in that research work. And then I shifted to hospital operations, and this is sort of an interesting story, but this was so long ago that I actually had to write the proposal to create a patient safety team at Brigham and Women's Hospital in Boston, because this was the early 2000s and there were no patient safety teams or programs.
How interesting.
So we wrote a proposal, got some money, and with a whiteboard sat down and said, okay, so now what should a patient safety team and program be? And so did that for about a decade, and then was a chief quality officer at the system in Boston that Brigham and Women's was part of, and then left to run the National Patient Safety Foundation. So that was a nonprofit that was doing work nationally around patient safety, and eventually we merged with the Institute for Healthcare Improvement. So was there as well, doing patient safety work both nationally and globally, and then lastly, I have been in the role that you mentioned at Press Ganey as the Chief Safety and Transformation Officer.
So it always blows my mind that in 2000, which was, in my mind, not too long ago, was the inception of the patient safety movement. So talk a little bit about those times and how did you get into that?
Yeah, so I actually started out as a researcher and was really interested in how we could leverage technology to improve quality and safety, because I just had this feeling that there were so many ways that we could make our systems and processes better with technology. And so I started there, and that was right around the time of To Err Is Human. And suddenly there was all this attention on patient safety, and I realized it's great to do the research, but what are we going to do operationally to actually implement those research findings in organizations? And so it was really a time when safety was brand new. There were quality departments, but there was not a focus on safety at all. And there really had to be kind of a convincing of leaders that this is something different that we have to add on. And especially the work around culture, especially the work around systems and human factors and all of these new concepts, the fact that we needed to change things so it wasn't so much about blame and shame, but really about driving improvement. All of those things were very new. So I still remember my first meeting. So I had been given some funding to create this program, and the CEO of the hospital said, here, I want you to meet with the chiefs of all the clinical departments and explain what it is that you're doing. And imagine I'm about 2 years out of fellowship at this point, so pretty junior. And I met with all the chiefs and told them what we were doing. And after the meeting, one of the chiefs actually pulled me aside and said, Dr. Gandhi, do you really think we make mistakes here at Brigham and Women's Hospital?
Aha, talk about culture of safety. That's an example of how not to create one.
Well, I was happy he did it after the meeting in a hallway as opposed to in front of all his colleagues. So I actually appreciated that. But I told him, I said, yes, I do think we make mistakes here. And he just, sort of nodded and walked off. But, that was where we were in 2000, 2001. I mean, really this lack of understanding of how big this problem was and, maybe a sense of hubris in some ways that we don't make mistakes. So we really did have to do a lot of cultural work.
So safety is really not only about mistakes, right? What is patient safety?
I mean, I do think of it as do no harm. And when I think about it that way, I think about it as well about how do we optimize care as well as prevent mistakes? Because we want to prevent harm. And when we talk about harm itself, I, over the last several years at least, have been thinking about a broader definition of harm as well. I mean, there's certainly physical harm that we need to prevent, but there's other kinds of harms that our patients and our workforce experience in addition to physical harm that I think we haven't necessarily paid as much attention to, but I think is also really important. So when I think of safety, I really think of it in this broader context of we need to prevent physical and emotional harm to our patients and our workforce, and we need to do that across the entire care continuum.
So you said physical harm, and then you said emotional harm. Tell us more about these kinds of harms.
Sure. So, physical harm, and for the purposes of this conversation, we'll talk about patient safety, though workforce safety, I think, is a really important area as well. And in many ways, we talk about that as a precondition to patient safety, because if you don't have a safe workforce, how can they possibly deliver great care to your patients? But for this, let's focus on patients. And so when you think about physical harm, it can range everywhere from a medication error that leads to renal failure to a missed or delayed diagnosis that leads to late diagnosis of cancer, to a fall in the hospital and, ending up with a hip fracture or something like that. There's a whole range of issues that can be physical harm events. Interestingly, our ability to measure these harms is still not great.
How do we measure them?
Well, badly.
But what are the measurements? Everything here that we do in healthcare, we measure. How do we measure safety?
So we try to measure physical harm in a few ways. I would say we still do it pretty poorly and are missing many of the harms. 25 years in, I think that's still where we are. So some of the primary ways that we measure are, one, through billing and coding data. So things that get coded, like falls, you can capture through that kind of data. And then we rely quite a bit on voluntary reporting of safety events from our workforce. The workforce reporting is very tied to culture. So, if you have a culture where people are afraid to report, you're not going to hear about things. But even if you have a really good culture, most of the studies have shown that reporting may capture 5 to 10% of what's really happening. So it's still only
5 to 10%. How do we know that it's only 5 to 10%? That's a little fraction of what we really need to learn about.
And even that 5 to 10% is probably, it could even be lower, because what they did in those studies is they compared what was reported to what was found through chart review. And we know a lot of things don't even end up in the chart. Mm-hmm. But compared to if you did a really robust chart review, you may only get 5 to 10% through actual reporting.
Wow.
And then the other piece that we've been missing all these years, I think, and has been a big focus of mine for the last couple of years, is patient reports of safety issues. Because if patients report things, it turns out a lot of the things they report are truly safety concerns, and a lot of those things are not in the chart and don't get reported by our staff. It's just another stream, another source. And so I think we need a much more comprehensive way to start to identify these things. And I am optimistic that with some of the new technologies coming along, such as, I'll say it, AI, everyone's talking about AI, but now that we have electronic health records, I think there will be better tools using AI where we can actually go identify harms without relying on human beings to report them. So hopeful that our measurement will get better, because right now.
Yes, but there's two different things. So the culture is really important. Culture of safety. What does it mean? People talk about just culture of safety. Can you explain what that means?
Sure. Well, so when I think about a culture of safety, I think it really is a culture where people feel confident that if they report an error, that the focus is really going to be on how do we prevent this error going forward, not so much on blaming of individuals. And I'll come back to that with just culture. But, especially, we talked about 20 years ago. 20 years ago, it was all about blame and punishment and so forth. So we had to really shift things to say, this is not about blame. This is about identifying the issues so we can drive improvement. And so, and it's really important in that to say, yes, we heard you, and this is what we're doing to improve as a result, because then people are more likely to report if they think it actually leads to a change. Now, initially, 20 years ago, it was all about what we call non-punitive culture. So we said, we're not punishing, we're going to improve systems. And then we realized the pendulum actually maybe had shifted a little bit too far. And we needed to have more of a framework that we call just culture, which is, in the vast majority of cases, it is not about punishment. It is about, coaching and counseling and training, and people don't intentionally, make these types of mistakes and so forth. But there needs to be a framework, because sometimes people willfully ignore what is a known best practice, and then there does need to be some accountability. And there's a whole algorithm to sort of understand how you work through whether, what the appropriate accountability is. But I think there was a bit of pushback to say, not in every case can we say it's non-punitive. So a good example that had come up in organizations is the surgical timeout. You're a surgeon, you will appreciate this. Implementing the surgical timeout was not very fun. It took many years for a lot of organizations to really effectively implement it. And then there were some organizations where there were surgeons who refused to do it. And so at some point, if you are refusing to do something that is the known best practice that the organization is saying you must do, and you don't do it, there needs to be a consequence for that.
So in your years since 2000, you've been in this field. Have you seen much progress and change? Are we harming patients less than we did in the 2000s? Are we getting better?
Well, so the data would say no, but I think there's a lot of caveats to that because of all the things I said about measurement. So, our ability to measure and find these events has increased. People are reporting more, et cetera. So it actually has been a little challenging to say quantitatively we are better overall. There are some areas that we've had good data to say that we're better, like, central line infections and other things. We have seen downward trends in some of those areas. I personally think we are better, but I'll explain why. But we have a lot of work to do still, because we have really predominantly focused on inpatient safety. We haven't even really focused much on outpatient. The emotional harm, which we'll get to, we haven't focused, et cetera. So, I think there's a lot of room for improvement. But the reason I think we're better is because there has been all this work around culture for the last 20 years. 20 years ago, we didn't even know how to measure culture. Now we have, validated patient safety culture instruments, and we can trend over time and understand psychological safety in organizations. And we have leaders who really understand the importance of that. We have, safety huddles. We have surgical timeouts. Talk about culture change. I told you it was very painful to implement the timeouts back in the day. Years of work. And now, if you're a surgical resident, you probably can't imagine a time when there wasn't the timeout. Just like you can't imagine a time when Houston Methodist wouldn't have had a safety program,
Correct.
Right? So to me, that's actual real progress. And, even when you think about training and education, you think about the measures that we do have, there's a lot of things that we've done. I get frustrated with pace of change sometimes, and I think, gosh, I've been working in this field for, 20, 25 years. There's still so many problems. And a colleague of mine, just yesterday we were talking, and he said, you don't solve big thorny problems in a short amount of time. These things take a long time. So it's, do I wish we were further along? Yes, but I do think we have made progress.
And talk a little bit about, you mentioned it, and I mentioned in the introduction that you focused on the outpatient environment. How is outpatient different than inpatient? In my feeling, just kind of as a physician, there's a lot of focus on inpatient and not very much outpatient. So share a little bit of your knowledge there.
Yes. So outpatient, I call the Wild West, because even if you say the word outpatient, there are so many types of outpatient care that are getting delivered. But the thing that I start with is the vast majority of care is given in the outpatient setting.
Almost 70%.
Right. You know better than I, compared to the hospital, right? So 70% of care is happening in the outpatient. And then you have, we have primary care, we have specialty care, we have nursing homes, rehabs, we have ambulatory surgery, we have dialysis centers, we have home care, we have hospital at home, we have virtual care. I mean, all of these different types of care, and they all have different safety issues. It's not like the issues that are in primary care are not going to be the same as in a GI clinic or in an ophthalmology clinic. They're going to be very different. So we just haven't invested the resources, I think, in outpatient. There are three main issues, I think, that have come to the top in primary care. So one is medication safety, and we know there's plenty of issues with ordering errors, and then patient administration errors, right? Because patients are at home trying to take these medications. It's very easy for mistakes to happen. And then issues around polypharmacy, where, you have your 80-year-old patient who's on 10 medications, and how can they possibly, manage that? So there's a lot of issues around medications and med reconciliation of, when patients are transitioning from inpatient to outpatient, or if they have, multiple doctors involved in their care. We used to call this what is the med list? And figuring out really what the correct meds were was really challenging. So that's medication safety. Then there's missed and delayed diagnosis. Really understudied area, hard to study, hard to measure. But when it has been studied, many estimates have sort of extrapolated that this is probably the number one issue in primary care. It's the number one cause of malpractice cases in the outpatient setting. And there's lots of reasons for missed and delayed diagnosis, systems issues, cognitive errors that, clinicians make where they fail to order something because they just didn't think of it, et cetera. So there's a whole field around diagnostic error. And then the third big area is really transitions of care.
The hands-off.
The handoffs. And as you think about inpatient to outpatient, or even nursing home to emergency department. And how many times do patients arrive in the emergency department and you don't have good documentation of what was happening in the nursing home and what medications they were taking and all that sort of stuff. And then does the primary care doctor even know what happened at the rehab and now they're home? And those are the top three in primary care.
So you would be delighted to know that we are focusing at Houston Methodist right now in our outpatient clinics on medication safety. That's what we're tackling. So you mentioned emotional safety. What does that mean?
There's been some really interesting research, actually, that has been done in the last couple of years, really talking about emotional harm and emotional safety. There's a BMJ editorial, Emotional Safety is Patient Safety. So when we think about emotional harm, it can be with physical harm. So, for example, you had a medication error or something and people didn't tell you about it, and then you found out later, or the way they told you about it was not done with, appropriate communication or language, or it was disrespectful, or it felt like something was being covered up. There's a lot of different ways that things can go wrong when the physical harm happens. And honestly, we haven't really captured that piece very well in safety for the last 20 years. We've focused very much on, the medication error led to renal failure, and now they're in the ICU. But what's the emotional harm of that? They didn't expect to end up in the ICU. Now they're in the ICU on dialysis. Okay, fine. They maybe eventually are going to be fine. But there's a big emotional impact of that on them and their family that we haven't quantified at all. And it's the impact of the harm, but then on the impact of how did we communicate about the harm? All of those things tie into that. So that's when there is physical harm. But then there's also this whole area of maybe there wasn't any physical harm, but there's still a lot of emotional harm happening. And this was really interesting work that started in Boston at Beth Israel in Boston, actually, where they had all these events where they said, there was no physical harm. It didn't meet any of our criteria to do a root cause analysis or anything like that, but we all cringed. Like we just said, I can't believe that happened here. Like it just felt bad. Somebody came in and we're supposed to have a procedure and no one called them to say this, the surgeon was away. So they drove, an hour and a half and they came in and then there was no procedure and then they had to go home and have it all rescheduled. You wouldn't typically put that in a patient safety type of event, but it had a significant emotional impact on this person who probably had to take the day off from work and come in and do all this stuff. Wasn't communicated to, probably wasn't, maybe there wasn't good communication even at the time, like, oh, sorry, we're going to call you and reschedule. And, without really thinking about the impact that it had on patients. And then if you think about the long-term impacts of that, it might mean that they don't come back.
Correct.
Right?
So there's a problem of trust.
Correct.
Trust in healthcare in general. And to me, it was a big shock, after the pandemic. In my mind, it was a very good example of how science and medicine and academic medicine and global medicine all collaborate to develop treatments, vaccines, tests, diagnosis tests. So it was incredibly impressive in my eyes as a physician. But then, to my surprise, there was an erosion of trust in healthcare and in science.
That's right.
And so this I would put in the category of emotional safety. How do we bring back the trust in healthcare?
I think, and one thing that I think is a starting point. So, we've talked a lot about measurement. So one thing that I do think is important is we start to measure and understand when these emotional harms are happening. And, certainly I'm at Press Ganey, we do patient experience surveys, which are often considered a proxy for trust. I mean, if you ask someone, what's your likelihood of recommending this physician or this practice or this hospital, that has been a proxy for trust. And we've actually started to look at a question about did you feel safe during your stay? And it turns out if you don't give a top score on that safety question, your likelihood to recommend, which is this trust proxy, your likelihood to recommend drops precipitously to the worst percentile.
Interesting.
And it doesn't recover. Meaning if everything else is great, your questions were answered, you were treated with respect, all the other questions. But if that safety question isn't a top score, your likelihood to recommend drops. And but to get at your question, so then the question is why, right? Why did you not give a top score? And so I think that's where, this is the leading edge of where we need to go, is now we have to ask these questions, but then ask the follow-up of, okay, why didn't you give a top score? What was it that made you not feel safe? And it might be, I noticed I had 3 doctors and they all had different plans for me. That doesn't make you feel very safe, right? It could be, I noticed that my room wasn't clean. Mm-hmm. It could be a lot of different things. So I think we have to dig deeper. And so there's research now, though, that is building frameworks of what patients mean when they don't feel safe. And so we can use those frameworks to start to dissect some of the themes out of those comments. And I remember with hand hygiene, this was a big thing, right? We put all those dispensers outside of the exam room, and then our patients didn't know we were sanitizing because it wasn't happening in front of them. And so then we moved them all into the room so patients could see we were doing it. I mean, that's a really important, right. And I remember physicians were like, but I did it. they're fine, they're safe, but they have to feel safe. And feeling safe is a really important thing.
Right. And I know these studies where the patient sees you wash your hands. And also if the patient sees that you are clean as a physician, and if you are wearing a white coat, just a white coat, it builds the confidence and trust.
That's right.
Even before you say anything. So you talked very nicely at the beginning about, safety is not only for the patients, is also for our staff. Can you elaborate?
Definitely. So when I was at the National Patient Safety Foundation, actually a year prior to my arrival, we had a think tank called the Lucian Leap Institute, and it put out a report called Through the Eyes of the Workforce. And in that report, these experts basically said what I said at the start, that workforce safety, which is physical and emotional safety, is a precondition to patient safety. Meaning, if your workforce isn't physically and emotionally safe, they can't deliver that best care to patients. Sadly, this was not a priority in healthcare at that time. This was 2012. And sadly, I really think it took a pandemic to finally elevate the conversation around this, which is disappointing. But now we're here, so okay, good. We actually have attention on it. So when I talk about physical harm to the workforce, certainly workforce violence is always front and center, and there's a lot of conversation about workforce violence.
Isn't that increasing nationally?
Well, so we have data at Press Ganey that's showing that reported assaults on nurses are increasing. However, what I cannot tell you is that more assaults? Or is that more reports of assaults? Because we have now changed our culture such that people actually report. Because a lot of this was very normalized. Like, this stuff happens. It's just part of my job as an ER nurse that I'm going to get kicked, hit, punched. I'm not going to report it to anybody. That was where we were. So I'm hopeful that the increase in reports that we're seeing at least is a combination of more reports as well as maybe an increase in assaults as well. But I'll also say physical harm to the workforce is not just workforce violence. If you look at OSHA data, OSHA collects data on things like slips, trips, falls, needle sticks, all those kinds of things. And pre-pandemic even, healthcare was more dangerous physically than high-risk industries like mining, manufacturing, and construction.
Wow.
Nobody knew that. I used to give talks about that, and people would be like, that can't be right. And I said, no, it's OSHA data. It's right.
Wow.
Healthcare is more dangerous because of these, the back injuries, the slips, falls, et cetera. And again, we always said the patient comes first. And I think that culture led to a lot of, back injuries and other things where people weren't concerned for themselves in trying to take care of patients. But then that leads to significant harms to that workforce, and they may not even be able to continue working. So that's physical harm. We have a lot of work to do on that front. And then emotional harm, even pre-pandemic, there were reports. For example, the National Academy of Medicine had a report in 2019 on the epidemic of burnout. So, even before a pandemic, we had an epidemic of burnout. And you can only imagine, or I'm sure firsthand, like since then, how things have gone. And so, we really have to think about the emotional harm to our workforce as well as the physical harm. And particularly if, we have issues around staffing and people leaving the field and all of this, like we have to pay attention. The good news in my mind is we have really interesting data that says if you work on safety and if your workforce really believes that you care about safety, for their safety and the safety of patients, and you care about quality, that is a driver of retention. It improves your safety culture, which is very correlated with improved engagement, because no one wants to come to work in a place where they don't think safety is, a really strong core value.
So you would be delighted that, one of our priorities this year is really the Joy in Medicine initiative. We gave it a really clever name, not me, but my team, called Jimmy. So we have the Jimmy tours, and we're visiting physicians where they are, and we're listening and really learning what they care about. And exactly as you said, people care about the conditions that help them deliver the best care to their patients. So you said physical safety, you said emotional safety. What is psychological safety?
Psychological safety, yes, is definitely a component of culture of safety. And it really is about, I think a good way to describe it is if you speak up and you're wrong, do people thank you for still speaking up? Right? Like you speak up and you say, oh, I think we have a missing sponge. Oh, let's stop everything. Let's look. Oh, turns out it's not missing. Do you get thanked for, raising that question, or do you get berated because you were wrong? Right? That to me is a great way to think about, do we have psychological safety? So it's really being willing to be wrong in front of your colleagues, knowing that you'll be supported, that, you'll be thanked for raising a question, raising a concern, et cetera. And it is a really important aspect of that culture of safety.
I am learning. I'm very much enjoying our conversation. And I'm going to conclude with a question that I ask all my guests in this show. What does quality mean to you?
I've always very much resonated with the Institute of Medicine, now National Academy of Medicine, kind of definition of quality. And I like the 6 domains, like the STEEP acronym, safe, timely, efficient, effective, equitable, and patient-centered. Like that really resonates with me as if you bring all those things together, that is the optimal care experience.
So I love that definition. Thank you so much, Dr. Tejal Gandhi. It's been such a pleasure to learn from you today.
Thank you so much.
And thank you for listening. Quality Time is part of Houston Methodist Leading Medicine series of physician-led podcasts. So that you never miss an episode, subscribe to Quality Time. New episodes will download to your podcast device. If you enjoyed our conversation today, please consider rating this episode and sharing it with your colleagues. I appreciate your support. Thank you, and until next time, I am always listening.